welcome you again, Integrating Behavioral Health into Primary Care and Overview. Let me tell you a little bit about Dr. Kos. He is a licensed clinical psychologist and behavioral health consultant. He received his undergraduate degree at Hartwick College and doctoral degree in clinical psych from Drexel University. He provides integrated primary care behavioral health consultation at the PHMC Care Clinic. This federally qualified health care center serves an urban population highlighted by presenting problems that include infectious disease, housing instability, substance use, and severe behavioral disorders. Dr. Kos also teaches professional counseling and physical therapy students at local universities and has published book chapters and papers on integrated healthcare, medical coping, and intellectual disability. We'd like to welcome Dr. Kos today, and I will share with you or ask Dr. Kos to share his learning objectives.
Great, thank you for getting me started here. I welcome everyone to the webinar. Hello from Philadelphia. Let me get this set up here so we can start with my presentation. And so here are the major objectives that we'll go through. I'll talk about why there's a need to integrate behavioral health services into primary care. I'll introduce several ways that this occurs, especially 5 specific models that behavioral health professionals can do to get integrated into the primary care or other specialty care settings. And then we'll talk as an introduction about how the behavioral health consultant functions and works within the primary care clinic. And further webinars in this series will give more details on this. And I will say, and I'll go into this a little bit more, it is site specific. So depending on the needs of the clinic and your population you're working on, the model may flex and change a bit. But I'll give you the generic sort of overview of what it looks like. There will be a learning assessment at the end, and that a question and answer period will be presented at the end to review the major topics. And as I go ahead and switch over to my screen, there are no financial disclosures I need to make here. And here's our general outline. I'll spend the beginning of our talk giving some background of why primary care needs this, what are the patient needs that really come up in primary care, and start to talk about the integration process, focusing for several minutes on the models that exist. And we'll focus particularly on one model, the primary care behavioral health model, that really highlights the key triple aims of enhancing health, enhancing access, enhancing quality of care. And we'll talk about how that model works in the flow of primary care and some of the basics about it, as well as the outcomes and how it is supported. And of course, I will save plenty of time at the end to answer questions and talk a little bit of how this really works in practice. So first of all, there's a high need to address a whole host of factors within the primary care environment. There are very high rates of psychiatric disorder and preventable health conditions. A stat that's been mentioned for a long period of time is 70% of the common medical complaints that come into primary care have some behavioral origin in nature, whether it is related to things like depression and anxiety, or it's related to risky behaviors, poor adherence, health factors that play into the mix. And if you do a sampling across primary care clinics, just your standard typical primary care clinic using a screener, about a quarter of people at any given time will test positive for psychiatric disorder. If you're focusing on some of the clinics where integration is most needed, where people have the most barriers to accessing care, those rates can clearly get over 50% in a short period of time. A lot of times, the medical providers feel that they can identify the people who need to access treatment. But most of the time, they do miss the silent suffering. And in a recent study, 48% of patients screened tested positive for a behavioral health diagnosis that was unknown. I can say from some of the research we've done at my clinic trying to identify and treat substance use as part of a large grant. Many times the providers were quite alarmed to hear about the really intensive alcohol or drug use that was occurring in their patients. And what we do know is a primary care provider will see a full spectrum of mental health diagnoses, everything from your run-of-the-mill adjustment disorders, bereavement, through depression, anxiety, substance abuse, and bipolar and psychotic disorders. On a given day, on a given week, about 12 hours of their time are spent directly to behavioral health conditions. So from our perspective, as many of you may be coming from the allied fields of behavioral health, these problems on the left are quite common. These are things within our wheelhouse that we traditionally treat, including things like IED, intermittent explosive disorder, personality disorder. I start bipolar and schizophrenia because those are conditions that we regularly see people having trouble staying within specialty care, such as outpatient mental health. And really the front line of treatment for these populations is primary care. In addition, some of the health disorders I'm going through on the right of this slide are really influenced by motivation of the person getting care and adherence. So a variety of things such as the focus on taking medication can really affect how well someone takes diabetes. And we know depression comes along very well with this. For many people, it's new having to, whether they have to inject themselves or take medication and change their diet drastically. These things really have a major behavioral component. And I can tell you a lot of these things on the right are the most frustrating part of many primary care providers' work because the improvement sometimes can stymie, and it can really be frustrating to a provider that wants to offer the best and help someone manage this. Furthermore, a lot of the primary care providers, whether it's medical doctor, physician assistant, nurse practitioner I work with, are really feeling unprepared for what they face in their jobs. That their medical training, despite being 1/8 of their time and about the number 3 common problem they face in their treatment, it's not learned so much in med school or nursing school or PA school. And therefore, they're having to attend trainings or learn on the job or piece it together. And a lot of the skill of detection, treatment, medication, they're trying to figure out on their own. What we also know is that about 50 to 60% of the medications for psychotropic conditions are being prescribed by PCPs, primary care providers, or OBGYN providers. And this can especially occur a lot with your common conditions like depression and anxiety. But as I alluded to before, they're having to manage very complex presentations of depression with comorbidity, psychosis, schizophrenia, and where substance use may be actively involved. And this can be quite overwhelming. In a recent study in New York by Smith et al., they've shown, overlooking the research, that about 1 out of 5 people that need some sort of behavioral health care are getting minimally adequate treatment, and a much more drastic rate of 1 out of 10 for those that are using substances in an abusive way or a high level are getting appropriate treatment. There can be this shell shock that primary care providers face of either fear of stigmatizing or going somewhere too sensitive for a person, or just that, I don't know if I can deal with this. So there's a lot of don't ask, don't tell. So I mentioned the triple aim that we seek for in healthcare, especially with the movement towards medical homes. We're now seeing things such as poor health, impaired quality of life, and increased healthcare costs because we're not adequately addressing these needs. And there's a whole litany of research that's outside of my talk here that goes into if you have a psychological condition that's untreated, you have a greater likelihood of having chronic health problems and developing significant increased health costs. Furthermore, when a provider identifies and has the ability to say, hey, I'm noticing this is going on, I really want to get you into treatment, referrals to outpatient providers tend to fail. 50% of a success rate with a referral to a community provider for therapy or a community clinic would be a high rate. A lot of the research I've seen hovers around 20 to 30%. And think about this. You go into your primary care provider, it may be the depression's the first thing you're addressing, or it may be something like a common cold or an injury, and your doctor, your nurse practitioner says, hey, I really think you should see someone. Here's a list of people. It's a very low follow-through. Sometimes it's a motivational factor, but more often than not, it's obstacles around time, transportation, access. Many community mental health clinics, especially someone who has Medicaid or Medicare, can have waiting lists that go on for months. And if you live in a rural area, there may not be a provider within 50 miles. So these are really important needs for integration. Furthermore, if we look at community mental health data, and the study that I'm coming from actually that isn't cited here is from a really intensive study that was done in Philadelphia. They found the average number of sessions that someone attended if they did connect to a community mental health center was 1. they attend to their intake. And most oftentimes they're not getting any sort of skill-based or some way to cope in the meantime. It's let's go through a bunch of papers, let's ask you a bunch of questions. Sometimes there can be support with that can make the difference. But it does draw the question that there may be a lot of unmet needs. And we also know that about 1 out of 5 appointments are no-shows to community mental health centers. So we're really not accessing the resources that are there in the way that would be appropriate. So as I scratch my head, what do we do? Well, the answer that's come up more and more and is the focus of this talk is let's bring the psychological services to where they're needed most, to where the population really would benefit most from care is. And that's primary care clinics. So I want to take some time to review some of the models that exist. Now, there is going to be a bias that I'm going to do towards more integration. And the model I'm going to focus on, I believe, is the most integrative. But you also have to look at what can the clinic actually provide, and we'll talk about large versus small clinics in the questions and how we make this work, and really what the focus is. So what you really want to be able to do is tailor to the need and what you're able to provide as a behavioral health provider to the primary care world. So let me first start with co-located. And what this simply means is either on premises of the medical clinic or maybe in an office right next to the primary care or community health clinic, a mental health provider may rent an office, maybe 1 day a week, maybe full-time, somewhere in that span. And what happens is they'll have an informal relationship with the medical team where they'll say, I'm right here, I'm renting space from you, please feel free to fill up my schedule with patients that you'd like to refer. And what would happen is it would probably go through the front desk or through some paper message, or maybe if there's some electronic sophistication through the electronic health record, which I'll call EHR for short from here on out. And then the person will get connected to care that way. It's really great because it provides an option. However, a lot of times there still isn't that same-day referral where the person needs it the most. And therefore, a con of it is while it may be easy for the person to get to around medical appointments, they're not meeting that person. They don't know who this person is most of the time. And it's just kind of another name, and that connection isn't made right then and there. On the other side of the spectrum would be the staff advisor model. So instead of setting up a shingle and seeing someone right on the primary care site or the specialty care site, you're instead working directly with the medical provider and staff. The provider is your client. So you're acting as a consultant who talks them through managing their practice on how to handle the difficult cases and things that they're seeing, like kind of doing case conference, being available for consultation where maybe they call you and say, hey, how do I manage this, or what medication might you recommend? As well as maybe pulling in on a difficult patient just to kind of listen in and give the feedback to the provider how they can better manage that situation. And there may be training and preventative factors in there. This can be really good as a way to introduce the service and show what a behavioral health provider can do for the providers and help manage all the stress that comes with doing primary care practice. But it isn't doing direct patient care in this model. It's more as a consultant to the providers. So let's talk about some other ways we can roll out integration. A takeoff on the co-located model is the primary care provider model. So in essence, you're still practicing independently. You would have your caseload of patients that you'd be doing some form of traditional outpatient therapy with, but you're doing a little bit more integration with the team. You may attend staff meetings with the healthcare team. There may be more of an enhanced communication than what might be typical. As we know as providers who've worked outpatient, it can be really hard to get a hold of your primary care provider for the patient, or their specialty providers, or even their psychiatrist. So this cuts down some of the barriers so you're able to communicate. Sometimes you might even share the same health record to some degree or message system. So you're able to talk back and forth and share the care a little bit. But in essence, a primary care provider model, the mental health provider is doing standalone care separate from the healthcare environment. And this would be considered more of an interdisciplinary model. If we go to step care model, this takes a number of different perspectives. It usually does start with a focus on doing some form of screening, usually by the medical team, where they can identify patients. So a common measure used in primary care is the Patient Health Questionnaire 9, the PHQ-9. And it's a very simple, quick to do, very reliable measure of depression. So let's say someone's identified with depression, and depending on their score and some brief interviewing by the medical provider, they might get slotted into some level of care. One, as a behavioral health practitioner in this model, you're going to do some training of the medical provider so they can know how to handle the different levels of depression and give them basic techniques that they can do. Maybe there's a nurse care manager that may help. And then you'd be available, depending on the level of care needed, potentially for 1, 2, or 3 very brief interventions with the patient that may be either scheduled that same day or more likely scheduled at another time, maybe the next office visit, as well as having the opportunity to flex and have a standard psychotherapy caseload. So as you can see in the STEP care model, we're trying to target part of the population. Let's say the depressed folks that are showing higher symptoms of depression and who need a little bit more care than, let's just say, medication or some supportive counseling from the medical team. So you would do some training to the medical providers so they can do some general tips and techniques like, here's basic behavior activation, here's some thoughts on cognitive restructuring that you can maybe do in a simple way for patients. And then you might do some drop-in quick consults to further that model for some of those identified patients, all the way up to actually providing formal psychotherapy. So we're providing a sliver of care for the greater healthcare population. Let me talk a little bit about the model that I practice out of and is kind of where we're heading with the largest form of integration working as a multidisciplinary team. We call this the primary care behavioral health model. It focuses on 3 things: increasing access by being co-located, collaboration where you're working directly alongside and with the medical providers and having feedback both ways. So the provider's giving you a reason why you're seeing them, and then you're providing advice and feedback as well as recommendations back to the provider. And there's a direct integration that is going on where you're working side by side and sharing the care and really involved in the moment. This is a very flexible flexible model where we're seeing someone often in the moment right as they're finishing up with the primary care provider. So the referral happens right then and there, and it's an open access model where you are seeing people on the flow throughout the day. You may schedule lately, but in general you're available to see anyone that the provider refers. And the way I like to think about this model is the primary care provider is my patient. I'm helping them with their patients or their clients, if we want to kind of use the standard behavioral health term. So you're working in the same space, you're helping them out. We call the variety of behavioral health providers that work in this model behavioral health consultants. And what we focus on is a very brief assessment. It's usually problem-focused to the referral need or specifically what's going on for the patient. We do brief interventions that usually have a more self-management component, things that the person can do on their home or with the support of their family. We're going to close the loop afterwards and talk to the provider and give them some treatment suggestions. This may not be like the treatment plan you write in outpatient therapy, but it's a very brief note that you're giving recommendations to the provider of here are some things to consider, here are some things that you may want to do, such as consider medication. I can follow up with them in 2 weeks to see how they're doing symptom-wise, and then I can see them at the next month appointment with you to see overall how things are going. And as needed, we do referrals to the community. So the PCBH model requires BHCs to make rapid and accurate assessments and treatment decisions based on limited information within a short period of time. Things move pretty fast in primary care, and people are used to a 20 or 30-minute visit for the primary care provider at max. Many times we go in there for a well visit, it's a 10-minute or 5-minute check sometimes. But unlike outpatient therapy, we tend to dive in as BHCs and be very directive. We set agendas pretty early on in the consult. We ask closed-ended questions to be able to get specific answers and broaden as needed. And then we focus in on the problem. And we follow a pathway that I'll show in a little bit, which involves agreement and advice on what's going on, education, teaching brief skills that fit very well with the self-management and the primary care model, and talk about practice afterwards. And unlike a outpatient intake where you may spend most of the time getting information and doing a detailed assessment, my goal is I want the person to leave with something. What little thing can I give them so when they go home, they have something to do that can start immediately working on the problem? So let's divide out the roles here. Let me start with the primary care provider. In this PCBH model, they're the team leader. To use a sports analogy, the PCP is the quarterback or the point guard here. It's their patient. They're running the show. I'm providing advice and counsel, and I'm helping out their patient to ease their flow so they're not spending that extra 12 hours a week really getting in deep with the depression and anxiety and other factors. The PCP is going to refer a broad range of patients to the BHC, and as the practice gets mature, it's not just depression, anxiety, smoking cessation. It's going to be the whole range of things, including patients that they're tripping up on, that they're finding difficulty with motivation and adherence related to their health. In addition, the PCP may use the behavioral health consultant consistently at certain types of visits. So in my clinic, it's half primary care, half infectious disease. So for anyone that's new HIV diagnosed, I'm popping in. I'm asked to do a yearly screening every year to see how our HIV population is doing. As well as anyone that's considering hepatitis C treatment, I'm involved in an assessment treatment process with the team where I'm making advice and following them through the starting of medication because adherence is crucially important. As well as child visits or initial diagnoses of diabetes or chronic pain. And in fact, I was asked by my PCPs to lead a chronic pain group so we can help better manage pain medication management in the clinic. In addition, the BHC is going to give advice to the primary care provider about what they're doing, what kind of interventions, and the PCP is requested to follow up on that. There also may be advice about starting medication, which the PCP would manage, evaluate, and prescribe. And as well as, while we talk about this as a brief model and we see people for limited encounters for a short period of time, what I like to say when I'm working with patients in primary care is, I want you to think of me as your primary care provider for wellness. I'm going to see you like your primary care provider at multiple times over your lifespan at this clinic. And it may help out one moment with this depression you're feeling, and then maybe there's some bereavement you're feeling later due to a loss, which also kind of acts as a relapse prevention. And then maybe there's just a need to talk because of stress at work or in a relationship. And those might be discrete episodes of care where I may be called in and I'm seeing someone over time. Or they might want to share good news of, hey, I just got this new job, or my kids are going off to college. So I tend to see someone throughout time as part of their wellness sporadically. However, I may refer to a specialist if they need more intensive behavioral health services, just like a primary care provider would do. And then my role as the behavioral health consultant is I'm taking about 15 to 30 minutes working with someone, sometimes a little bit more, either directly in the exam room they were waiting for their medical provider in, or in a side office. The provider is going to directly hand off the patient immediately with a stated concern. They're going to tell me, Ms. Jones, I'm concerned about her. She's not taking her medication the way she would, and I think she's depressed. Can you address both those issues? So I'll go ahead and take that information, and I'll try to zero in on that in the consult. I'm trying to focus on getting a brief assessment of their depression and how that's affecting their life, what barriers are in the way to them taking their medication, providing some education, and doing some intervention, typically motivational interviewing or something from the cognitive behavioral family, or even very brief supportive listening, feedback that can be very helpful. Also, I may see people when we're seeing a problem happening before it does to give some advice on, your drinking's starting to get up there a little bit. I want to talk to you about healthy limits, and this might be something to watch out for. Or doing clinic-wide depression screening where the MAs, the medical assistants, may screen and give me that feedback so I can start to catch people before they develop really full-blown depression and to see if we can start doing things preventatively, as well as with stress management, better adhering to health, smoking cessation. I'll refer where appropriate, and then I follow back around to the primary care provider to talk about what we talked about in there. So you do have to contract with patients a little bit differently about confidentiality. And even the way I write my notes, it's going to be seen by the whole medical team in the EHR. So there's a whole different approach to how we write notes and how I talk with providers and patients about the care I offer. Hence, I'm not a behavioral health therapist. I'm a behavioral health consultant. And just like any medical provider who's referring out to a specialist for cardiology or neurology, they're going to want to report back. Well, same thing here. Once again, the primary care provider is a quarterback. I'm just giving information that I'm getting from that limited time I have with the patient to better help with care. So some of the things I do is I teach evidence-based skills to patients. I focus on things that they can do at home. I make specific recommendations to the primary care provider. I help with medication education about what side effects they might expect, when that may tend to go away, when the medicine may work, and support adherence to the medication. Note, I'm still staying in my competence as a psychologist. I'm not prescribing. I'm not saying these medications should be given, or you should watch out for this, or you should change your medication around this way. I'm just providing general advice and education, sitting down around what may be some of the barriers around care. And I always keep in mind that the patient's the PCP's, not mine. So I'm just trying to help out with care and provide the best for the moment. So here's what the workflow looks like. And this all is going to depend on what your clinic needs are and how busy it is. Now, I work in what we call a relatively small clinic. We have 3,000 people. That is our general population of patients. However, some clinics are closer to 10, 20, 30,000 patients in the greater panel, even larger in some cases. So my role here is we have a lot of people that come in for infectious disease visits where they're coming in monthly for HIV follow-ups, for chronic pain, to get their hepatitis C care. So I'm seeing the same people a little bit more often. So I may be doing more follow-ups than, let's say, a large clinic behavioral health provider. But in general, the numbers stay pretty similar. An average day can be anywhere from a little bit less than 8 to 12 plus. And when you're doing 20 or 30 minutes, it's going to fill up a good chunk of the day. My most typical way of getting patients, this is going to be well over a third of the people I see in a day, is that warm handoff, where the quarterback kind of passes to me, the running back, the behavioral health provider. Hey, I want you to see this person. This is the concern. This is my specific question. The first thing I'm doing is checking in with the patient and saying, does this sound like something that's your concern, or do you have another take on this? And trying to get their scope on this, but not leaving it broad of, what brings you in today, or what can I do to help you? That can take me in many different directions. I do want to do an assessment of what's going on biopsychosocially in someone's life, but I really want to focus as much on the problem as I can. And there's something beautiful about the warm handoff because the person has a lot of faith in a primary care provider. They've been going there either for a while or just the medical culture has a lot of weight. So they've already started to talk with the problem, and when the provider says, hey, there's someone I really trust that works here that can help you, I'm going to bring them in the office right now and introduce them. It allows you to jump in a lot sooner, and there's a lot more trust given to you from the start because you're working as an extra part of the primary care provider. And what really, this is kind of the engine to the model, is this relationship with the provider and how we're able to build off of that. In addition, I may do follow-ups where I'm going to follow up with someone, assess how they've been doing the interventions we've talked about, provide additional instruction, skills, support, and assess the change that they're making along the way. This is usually done at the next office visit for the medical provider, but it may also be done at another time in between or via the phone in some cases. And then I do cold calls where I may have a certain pathway I'm checking in. So for example, this month or the next 2 months, I may be screening all people that come up in our record as having diabetes to see what their depression is like, since we know that's a common problem. Or I might be seeing people that I see have been talking with the provider about quitting smoking. I may follow up with them to provide more help before they see their primary care provider. Another thing I tend to do is anyone that's new to the clinic, I'll try to do a quick drop-in with them to see what brings them in, talk about the services we have at the clinic, and maybe do a screening for depression or anxiety or another concern that becomes clear with talking to them, as well as helping out with any forms to get them going for the provider. Likewise, there's the plus, and this takes up a good chunk of the work. It's the follow-up with the providers. It's answering their questions or providing advice to them on the fly in the hallway or in their office, keeping HIPAA and confidentiality in mind, but talking really carefully and helpfully about what can help their practice. I also might stick my head in before an office visit just to say, hey, how are you doing, Ms. Jones? We talked about your depression last time. How are you doing? If that was a case where we didn't schedule follow-up, as well as making phone calls in my free time and helping with referrals. So the type of interventions we do are geared to things that can be done briefly, can be readily accessible by the patient I'm working with, and fit well in their life. A lot of times it may be just listening, that they may need to talk about what's going on and have some support. It may be education to normalize what's going on, especially in terms of grief or a stressful situation in their life, or to give them feedback of, it sounds like you're dealing with a condition like panic disorder or generalized anxiety disorder. Let me give you some information now and some information you can take home to look at later. In addition, it's going to be things that we can work on collaboratively very briefly, such as teaching stress management techniques, doing behavioral activation to get someone moving with depression, helping with pain management, doing some brief cognitive behavioral therapy. I may not do a classic Beckian restructuring, let's do a full thought record, but I do use that from time to time. But maybe I can help to identify distorted patterns of thinking and try to give handouts on, here's some things you may want to watch out for in your thoughts. Over the next week or two, try to keep track of that. And then let's see if we can come up maybe with alternate ideas the next time. And one thing that's getting a lot of traction is acceptance and commitment therapy. It really brings in values and functioning. And in this sort of approach, I can talk quickly about what's important to someone. Dr. Patty Robinson will talk a lot more about this in her webinar. She's done a lot with acceptance commitment therapy in the primary care setting and can talk a lot to how this can be useful, but it's something I'm using more and more in my practice. And the bread and butter of my work is often motivational interviewing, trying to quickly assess where someone's stage of change is, what they're willing to do, what barriers exist, and try to move them along that path through motivational interviewing to be effective. So as you can see, my keys are the interventions I use should be brief to administer, acceptable to the patient, and things they can do at home on their own with minimal education and training. I see a lot of patients that could benefit from really deep therapy or insight-oriented work. I may try to refer where possible in those cases, but I can't really get into that in this nature of it. So I'm really focusing on functioning and looking out for other flags that may exist that this person may want to work on. So here's the generic approach that a lot of behavioral health consultants take off Christopher Hunter's and colleagues' work. And this is a really kind of touchstone model that helps guide the work here. The first thing we do is an assessment where we focus on briefly assessing what's going on, what clinical problems are at result, getting some provisional diagnoses, as often the insurer may need that to bill if we're doing a fee-for-service sort of model with the insurer, and really getting a sense of what is the problem, and that's in a really functional behavioral sort of way. What are the antecedents that cause the problem? What is the problem itself? What's the consequences of it? And what has the person tried to do to modify this? What skills do they have, and what barriers are there to giving care? After that, I'm going to give some feedback to the person and say, here's what I think is what's going on. This is maybe the diagnosis I may think is play or the problem. Or here are some possible solutions that may be helpful to help with your problem. Which then we go into working on an agreement where we negotiate this and develop a plan of action. Either at this visit we'll do some things, or the next time they come in we can do something to further help with this. I have a lot of friends that are lawyers, and my lawyers, I know they joke that they think in 6-minute increments, that there's 10 billing increments in an hour. And it's funny, as I've become a BHC and done this over the years, I've noticed I think in like 5 to 8 minute increments more and more. Okay, my first 5 to 8 is let's do an assessment. My next 5 to 8 are let's negotiate this and agree on a plan with some education given to the person. And then I'm saving some time for assisting and then wrapping up, where each of these 5 to 8 minute increments fill out the 20 to 30 minutes I may work with someone. So as a result of this, my next part of the intervention is going to provide some education that's agreed upon, some skill training, or brief interventions such as support, listening, helping them guide through some restructuring if that's appropriate, or problem solving, where I may do a bulk of the problem solving to give them some solutions of what they can do to help, and then maybe later train those skills if I see them at another time. And then we arrange of what can the person do at home, the homework, to kind of continue this going. If someone needs a referral, we work on that, trying to get that set up with the community. And then I follow up as appropriate. Some cases I might just pop my head in the next visit and say, hey, how are you doing? Did those work? If someone's doing quite well, there's no need for further consult. Other times I can tell in advance, or the person may want to schedule a follow-up. And I quickly will give a rundown of how the model works, and I do open access, but I do have some slots reserved for follow-ups, or I'll try to get someone in around their medical appointment at the next time they're in, so I can see them either before or after they see their medical provider, and they're prepared to stay that extra time if they need to arrange child care or work time off. The most important part is after I do my 5 steps, it's close the loop with the primary care provider to give some feedback to the provider of what happens. So in the last, say about 7 or 8 minutes, kind of going with that model I just talked about, I'm going to give you some evidence of how this model really works and some of the growth opportunities. About 6 to 8 years ago, I can't remember exactly, I sat in my first workshop, actually led by Dr. Patricia Robinson, on this issue of doing the primary care model in the behavioral health, the PCBH model. And I remember sitting there through the workshop thinking, really, does this work? Does one consult for 20 minutes really going to make a difference for someone? I was a doubter. I had another question, which I'll get into in a moment later on. Like, really, is this going to work? I had a passion for working in medical settings, and I was eager to try this. And I quickly saw that people really do benefit from taking some time just to discuss what's going on, to get some of that out, and to get some quick, helpful hints to begin to manage it, and at least get on the road towards addressing this, or to start thinking about making changes around a problem. I can say from my personal experience, some of the research I'm going to show, this really makes a difference. And I think it goes back to that warm handoff by the provider. There's that connection. The person's already starting to talk about this in the visit. So let's just carry it forward and meet them really in a problem-based sort of way of, here's some things that can help you. So there's been a lot of research that's come out on this, both recently and over the couple decades or 3 decades that this has been formally in practice. It's been informally in practice in other ways before that. Here's what we tend to see. One, there's reduced health care costs. So if someone's getting an intervention and then they're able to do some self-management, some coping, it reduced medication costs over time, unnecessary hospitalizations, it better improves someone's adherence to their health care if they're not feeling depressed or anxious. These things really can improve that. Also, we've noticed through rating scales, people's symptoms go down, especially related to depression. We have a whole host of research on that. That in as little as 1 or 3 consults, this can make a difference. And people do report enhanced functioning on measures like the HUDAS or other measures. We don't have a lot of great primary care measures. We have some really good ones that can help, but I think that's a field for further development of how we can better capture how people function. And in acceptance and commitment therapy, there are some good things with bullseyes and values to relate how well are people doing with things that define their quality of life as well as their health care. Primary care providers report this is great as reducing their total workload and their ability to focus on what they need to and be able to kind of pass off some of the things that they don't feel as expert on. And we've seen time and time again that this can really improve how patients feel about their clinic. They feel a greater anchoring that, wow, they're really helping with my care. There's someone that can provide support as I need it. And I have more trust in my medical provider or doctor as a result of this. Some things that we've seen is we see a significant drop in clinical measures such as the PHQ-9 for depression. After at minimum one visit, we've seen some significant drops that can occur over time as a result of this. Depression's been one of the easier things to measure, so we've captured this more. So in very small-scale trials of 1 or 2 clinics or very broad things like the IMPACT, which use more of a step care model that I talked about earlier, you can see really substantial changes in primary care level depression. And the symptoms can be maintained at a reduced level and improve functioning up to 1.5 years and 3 years out from 1 to 4 brief sessions with a behavioral health consultant. A fascinating study I just read was, and in my clinic we see a lot of people coming home from prisons that are in halfway houses returning home, and there's a whole host of stress with that, difficulty finding a job, difficulty reintegrating with the community, risk of reincarceration. And one primary care clinic started to introduce their staff while people were still incarcerated, and when they were released to the local halfway home, they were encouraged to connect with that primary care clinic. And you saw better adjustment and reduced recidivism of going back to prison and follow-up. So this is just something outside the charts that no one even thought to evaluate before and how primary care can help with this. This is some research from Dr. Patty Robinson, who does talk about some of her variety of things that we've seen depression drop. And healthcare costs can drop over $500 by just doing some brief depression counseling in the long term for medication costs, health utilization costs, and there can be definitely a better likelihood for the person to stick to their medical appointments and follow up if they know, hey, I'm going to talk to someone that's going to listen to me and provide me some support. What the heck, let me go in on that bad day where it's rainy out or I really don't feel like going to the clinic. We also see a greatly increased connection. So as I talked about, less than 50% of people connect when their provider says, hey, I want you to see someone out in the community for behavioral health. And the more integrated someone is in the practice, the more multidisciplinary the care, the higher the rate someone's likely to stick. If it's co-located, you're going to see better than 50% because it's right there. There's less obstacles. So the person may come back at their next visit and schedule an appointment with that therapist. But if someone can see them right on demand, as I do in my practice, I joke with my providers, there's no interruptions. If I'm sitting down with the patient, if I'm on the phone, if I'm talking to someone else, knock on the door. Get me because I want to triage and know. It's very different than what we're used to doing in the outpatient model, but it really allows people to get the care they need. And most of the patients I'm sitting with understand that they were that knock on the other door before when they really needed the help. That Yeah, it's okay if you get interrupted for a couple seconds. I come back. Most times I can finish up with the person I'm working with, or if there's an urgent issue as an emergency, I coordinate with the person to see them again. It works out really well, a lot better than you would think. But 80% of people successfully connect, 70% on the same day. I think reactions are really where it tells how people are doing on this. And my primary care providers that I work with are really gushing about this model that's really improved the care they can provide for patients. They see their patients getting better both psychologically but also medically. And one of my providers said, I can't imagine practicing now without it. It would be a nightmare. The patients I talk to really matter in how they feel about this. And that it's so nice I can talk to someone when I really need it at the clinic. It's a thing I hear quite often. I may not see someone on an ongoing basis, but it's intermittent. Every few months or every few years, someone may drop in to talk with me. And that's a really useful service that can really help people over time. And I've had a lot of success stories where a couple interventions really made a difference for someone going to access substance use care or starting to change things in their life or make life sort of changes that overall help things, such as accessing therapy or leaving a job that wasn't helpful. So where are we going with this? Well, first, with the Patient Protection and Affordable Care Act, commonly known as the Obamacare, we are seeing a greater emphasis on integration, and especially with patient-centered medical homes, improvement of access to insurance, a variety of whole factors that can really are helping people better access. With providers asked to do more and more and to kind of squeeze out more of them, they're constrained. They need their help in managing their practice, managing their stress, managing their patients. So there's a need for this. As we go on time, getting help for these concerns is less destigmatizing. There's less stigma with it. And especially when it's right there in your clinic, it's just another service we offer, it takes away a lot of the stigma. And when I jump right in of, how can I make you function better? It's not, let's get into everything from your past. It's, let's try to start with this here now. People really buy into that and see it as practical in their life. We'll have some questions about, I imagine, about insurance and how this pays for, and that was my second question. I am starting to see insurers greatly see that there is some benefit to providing these services and that there's some downstream costs that can be prevented if we address it in a preventative or early on way. So there is a growing acceptance, especially within Medicare and Medicaid, to fund this, and private insurances are following along. So where do we see co-located care all the way up to integrated care? Well, the VA and military clinics as rural community mental health centers, medical centers, have been doing that for a long period of time, as well as university medical systems. I work in an FQHC where that is becoming part of the patient home, where the medical home is requiring that, and that's part of our mission as a FQHC is to have someone there to provide support. Now, when we get into more of private primary care, it's a little bit harder to reimburse for these. The models are there. So what we tend to see are BHCs that maybe do part of their care where they're doing a traditional practice, but they may spend a couple days a week, which the medical center is willing to write off because it allows their providers to be more efficient, it keeps people coming, and they see a multiplier effect of having someone in that clinic for 2 or 3 days for consults that sometimes can lead to a full-time, you just be there for availability and we'll pay a salary for you. We don't have to worry about a reimbursement, or we'll reimburse where we can. There's also a need where there's a big behavioral component such as OBGYN, sleep clinics, cardiac care, you imagine. And we're starting to see non-traditional options. We're seeing reverse integration where medical providers are being brought into community mental health centers. I work with a lot of physical therapists in training. There's really a need for BHCs in that sort of model, and we can get really creative throughout. Pediatric psychology is also a field where this is being done. A couple last things. I know I'm near the time I said. The maps here in the dark colors show where there's a high degree of integration of psychologists co-located at least, near a medical clinic within the same address that Benjamin Miller recently did. As you can see, there's big parts of the country that are that white color where there's minimal access. And usually there's minimal access to therapists in the general area. And as you can see in this blurry side, the more rural we get, the higher that number goes to 9, the less access there is to a psychologist co-located or any behavioral health provider. We're talking about 10, 20% in the lowest rates where there's already limits in getting there. And there are programs out there that do loan repayment that encourage people to go out to rural areas or underserved areas to really provide that need. So there's going to be a very booming job market here. As well as with the baby boom, we'll probably see this in nursing homes and other facilities as well. Now there's some barriers. You have to get buy-in. You have to get clinics to be willing to start up this. There's some startup costs. You have to get insurers and local behavioral health provider insurances to be okay with this. So there is some sell, but we're seeing greater buy-in as a whole. In my experience, I'd love to see a lot more medical and preventative health factors, and the bulk of my referrals are behavioral health oriented. So there is a kind of a push to let's also try to help with health and find reimbursement models to be able to do this, to improve medical care overall. And then there's also training needs. There's a lot of flexibility, there's a lot of knowledge that is needed to do this. You're able to learn on the fly and to be able to get this at conferences and training, but we do need to fill that need a little bit and get the training ready. So there's some great books. The book on the left and lower right are commonly used textbooks, kind of the classic texts, the Integrated Behavioral Health and Behavioral Health Consultation. The one in the middle talks about the models and how to really unfold this and roll this out. And Dr. Serrano's book is really kind of a step-by-step of how to roll this out as well. So these are great resources you can find, and this PowerPoint will be posted afterwards for your access. There's also training opportunities. CFHA has their conference coming up, these webinars. There are great opportunities to learn a lot about this. Other conferences, including Society for Behavioral Medicine and the Association for Behavioral and Cognitive Therapies, really do have tracks and seminars that focus on doing this work and workshops. And to get dedicated training, UMass has their own integrated primary care certificate program that can get you trained on how to do this. As well as, if you're a psychologist, there's internships and postdocs and postgraduate opportunities. So that covers the bulk of this. I'm happy to take questions. I will go to the kind of final post-assessment questions that we do have that review the learning objectives that I talked about. But eager to take whatever questions I can in the time we have.
Thank you, Dr. Koss. We do have a few questions coming in. One of the first is, how can integration be successful in small primary care clinics?
That's a great question. And the one thing I've typically noticed is my colleagues that work in the bigger clinics, you have to be more available on demand to work with the providers and do more education of how they can manage the lower level, more chronic things that they can try first with patients. In smaller clinics, you may have to change your model a little bit. It may not be the full PCBH model, where you may still need to schedule some outpatient appointments. Or you may need to kind of flex the way you deliver care, maybe doing some group-based things, or such as in my case, which is smaller, but the patients come in more often due to their infectious care disease, you're doing a little bit more follow-up with the given people until they seem to be set or connected to care. So it's just kind of changing the model of your practice, or even how many days you're in at the clinic, to then match what the needs of the clinic are. And that would be through negotiation with the site specifically where you'd be working in your own time that you have available.
Very good. Very good. And as a reminder to all of the participants, if you'd like to ask a question, you can raise your hand and I will unmute you, and you can ask that question verbally, or as an alternative, you can type the question in the question box in the navigation panel on the right-hand side of your screen. Another question that we have: what are the different challenges in a large versus small clinic with integration?
Well, I think with a large clinic, the challenge sometimes can be, it can feel like a lot coming at you, and you have to really remember your consult role, that you're there providing support, education. You may not be engaging as much follow-ups and therapy with someone, and really you're kind of being access to be able to help in the moment what the person needs, and then helping triage what support they need. In a smaller clinic, it might be meeting productivity domains to see enough people to be able to get certain providers. If you're in a smaller clinic where there's 3 or 4 providers, I always find there's one provider that's very gung-ho and gives you a lot of referrals. There may be one that doesn't give you so much, or gives you more of a specific kind of referral, like, yeah, you can help with smoking or just depression. And you need to do some education and motivational interviewing work with that provider over time, where I'll often say, give me your toughest person, the person that makes you bang your head against the wall, the one that you're really struggling with, and I'll see what I can do to help you with that. And then that's a way I can do some buy-in.
Very good. Our next question relates to billing practices and employment of behavioral health. And this individual wants would like you to share how billing and employment of behavioral health is managed in that PCBH setting, or particularly in your setting.
Sure. So let me speak to my setting first, and I can talk more generically. So I'm a salary-based employee. I'm not fee-for-service in any way. Some sites, that's the basis, is there's quotas or bonuses for seeing more people. But we've worked out a very nice arrangement. We have a federation of behavioral health consultants throughout the Philadelphia area that work in these federally qualified health centers and specialty clinics. And we've worked out an agreement with the County of Philadelphia, which does their own behavioral health insurance, to do a specific rate for when someone's seen in the primary care environment. And that's really worked out well, that we can bill a certain rate based off Medicaid and Medicare for psychological conditions to be able to see people that need the care within the primary care, kind of with the assumption that I'm not going to get in long-range therapy for someone. That really should be referred out to outpatient therapy as needed, so we're not kind of taking away from the system, but that I'm providing care that's needed in the moment. And likewise, Medicare and Medicaid has these health behavior codes that you can bill under to provide assistance related to stress or needs around a health condition. So those are codes that can be used as well to get reimbursement. So in my agency's factor, I'm paid salary. I have expectations of roughly how many people I should see a day to kind of maintain my employment and also the infrastructure needs, such as through HR, my supervisor, the trainings I go to, having admin time to be able to do notes and a variety of different things and educational trainings. Other places, they've worked out, similar agreements with the insurer. They'll do flat rates, and then a way that some of the extra overhead can be covered is through group work, or someone might have a one-day-a-week clinic where they're doing standard outpatient therapy to help meet up some of the difference of this. What I've also seen is in the case of a small clinic where they might do kind of either through a grant or through willing to take a risk, paying a consultant rate for a BHC for, let's say, 1 or 2 days a week, just to see how it goes. So they might say, we'll pay maybe $300, $400, whatever it may be negotiated, maybe even higher on a given day or less, and say, okay, we're going to pay you a flat salary. I want you to monitor outcomes to see what time saving are we doing for our providers. Are we seeing more patients as a result of that? How are people improving? To see if it's worthwhile as a cost-effective way. And then so that can be just a straight salary paid from the clinic overhead as like a cost, just like paper supplies or staff that doesn't generate revenue, to see if that can work, and then over time investigating ways to get reimbursement. And things like the VA, that's going to be readily paid as part of the greater model that they have in their insurance plan.
Thank you. Thank you, Dr. Koss. We're almost out of time, and I'm seeing that we have a few more questions. Let me let everyone know that I will be forwarding all of the written questions to Dr. Koss, and we'll ask him to respond to you all individually. We will be sending you an evaluation for this session, so if you would help us learn from our these webinars, what we need to do, what we need to improve on, and what we need to do better, or perhaps topic areas that you're interested in. We'd appreciate that. Please remember that our CFHA annual conference is next week in Washington, D.C., October 16 through 18. We will have a number of sessions, including some pre-conference sessions on the PCBH model. So if you have not registered and can possibly do it at this late date, we would highly encourage you to do so. We'd love to see you there. Our online registration stays open until October 10th, so just another couple of days. So please consider doing that if you have not yet registered. And finally, I wanted to make note again of our next upcoming PCBH webinar, Brief Intervention Skills for Primary Care Providers and Behavioral Health Consultants Working in the PCBH Model. It will be Wednesday, November 12th at 12, so mark your calendars. Patty Robinson will be the speaker. I think Dr. Koss cited some of her work in his webinar today, and so you'll be able to learn more from her at that time. That being said, I'd very much like to thank Dr. Koss for his time today. It was a a fantastic webinar. I think it provided a great overview for our next webinars in this series. So thanks to all, and please remember to fill out your evaluation. Thank you.